Good morning. Let us touch on the basic radiographic evaluation of bone lesion. We have our usual 7 X-ray questions or evaluations. This is usually used to help the clinician to have an initial evaluation of the bone tumor. It is not applicable to soft tissue lesions. This will give us the answer on the aggressiveness of the lesion and not the diagnosis. We have the first question. Where is the tumor? The location. We will ask what specific bone, where along the bone, and where in actual section of the bone. Possible answers may be the following. We will have central or centric, eccentric, cortical, anywhere along the cortex, and juxtacortical, like abutting the cortex or just within the periosteum. Second question is the size. What is the size of the tumor? We have a fairly large if the lesion is occupying the entire area of a metacarpal compared to a lesion occupying just half of the area of a femur. But when you compare the two, obviously one will say the lesion is the femur is bigger. The size is usually in relation to the bone affected. You have the third question. What is a tumor doing to the bone? Our cue for this is you look at the lesion and describe it. Usually you describe the behavior of the tumor or the lesion by the following A and B. A, by its density, and secondly, by its border. When you say density, you describe the lesion either lucent, lytic, sclerotic or blastic, or mixed, lytic and blastic. By its border, you may say geographic, well-defined, sclerotic, geographic, well-defined, non-sclerotic, or geographic, ill-defined, or less delineated. Geographic means you are able to see the lesion's border, or the lesion's starting and end point. Look at the skull X-ray, you have that characteristic of a moth-eaten appearance, and the proximal femur below is the permeative one. To illustrate, we have letter A, we have geographic sclerotic. We have geographic non-sclerotic for letter B. For letter C, we have geographic ill-defined. Okay? Although it is still defined, you can still see the borders of the tumor, right? Where it starts and where it ends. Letter D, we have moth-eaten appearance. Letter E, we have permeative appearance. Fourth question. Fourth question will be what is the bone doing to the tumor? Our cue for this is our host bone response. And you should look at the periosteum. This will be answered by the following. It shall be non-aggressive if the periosteum looks thin or thick, solid, septated, or irregular. While aggressive lesions appears like laminated, like an onion peel, spiculated, like an hair on end, sunburst. We have also, if the periosteum looks disorganized, it may be a sign of being an aggressive lesion. Presence of Cudman's triangle maybe also tells us that this lesion is an aggressive one. Kedman's triangle is the name given to a periosteal reaction that occurs when bone lesions grow so aggressively they lift the periosteum off the bone and do not allow the periosteum to lay down a new bone. It is a pattern of interrupted periosteal reaction where the periosteum gets lifted at either end of the aggressive lesion. The central aspect of the lesion does not have any overlying ossification. Just look at figure letter I. This is the periosteum being lifted by the tumor. This is the lesion insinuating between the periosteum and the host bone, forming a triangle shape. So if I ask you what are the borders of Cadman's triangle, superior border, periosteum, inferior border, the host bone, and the base will be the tumor, the lesion. We have letter A. This one is thin sclerosis. B. Thick sclerosis. C. Irregular appearance of periosteum. D. Depleted. These four A, B, C, D suggest that this lesion is or are non-aggressive. However, for the E, F, G, H figure I pertains to a possible aggressive lesion. Letter E is the onion peeling. Looks like onion. Laminated one. We have hair on end appearance. Of course, we have the sunburst appearance, and then we have the disorganized periosteum, figure H. If we have these figures or seems looks on an X-ray, you may have a clue that these lesions may be aggressive. A X-ray, we have the hair on end configuration. Look at the scapula, hair on end. On the middle X-ray, this is the X-ray of femur. Take note of this periosteum being lifted. This is the host bone, and inside, in between those, is the lesion lifting the periosteum, forming your Cadman's triangle. Obviously, this is your lesion, the blastic. This is what we call osteoid matrix. Figure C pertains to an X-ray of the femur, which has a thick periosteal reaction. The thick periosteal reaction is very obvious on your CT scan. Okay? Your periosteal reaction. Take note, you can see also thick periosteal reaction in an infection. Now, it's really up to the physician or the residents or the doctor evaluating the patients. Okay? If this one pertains to a possible infection or a possible primary bone tumor. Fifth question. We have cortical break, followed by the sixth. If there's a cortical break, eventually will there be any soft tissue presence? And lastly, we have the matrix presence. For the cortical break, this is always the same in an aggressive lesion, where there will be an eventual break of the cortex and being able to catch up with the exponential growth of the lesion and the tumor grows out of the bone. Sometimes there will be a reaction where the periosteum can catch up with the lesion, forming what we call neocorticalization, means new cortex, which may be observed in GCT, giant cell tumor, aneurysmal bone cyst, chondromyxoid fibroma, chondroblastoma, etc. And take note, these lesions are benign if you have no corticalization. Eventually, if there is a break, there will be a soft tissue which will be palpable and can be readily seen on CT or MRI. Take note that not all palpable mass on your PE represents a possible cortical break and soft tissue. Sometimes it is just the lesion itself inside the bone which expanded. This may be a sign of a non-aggressiveness behavior of the lesion. For the matrix, we have possible answers for this one is osteoid, chondroid, or fibrous. Some matrix can be seen clearly on an X-ray. Others commonly will be seen through microscope. Okay. If we don't have any matrix, you will not appreciate any matrix on X-ray. The answer is none, no matrix at all. Osteoid, if we have osteoid, we have cloud-like, fluffy or ivory density. For chondroid, it appears as arcs and rings, stippled or flocculent. We have granulus for fibrous. Okay, just like in figure 8, we have this X-ray of the femur. There's a cloud-like appearance. Seems like a cloud-like appearance on the femur. For figure B, C, yes. Look at this granulus appearance encircled in the red. Okay. This is fibrous dysplasia. Any fibrous lesions will have or may have a fibrous or granulus matrix. Look at proximal femur. We have geographic sclerotic lesion. Distal femur, we have stippled, okay, on the distal femur intramedullary, which represents a possible cartilage lesion. While on your proximal tibia, we have a mixed lesion of blastic and lytic. Obviously, on CT, there's a cortical break here. For the soft tissue goes out, the lesion or the tumor goes out, eventually goes out and forming a soft tissue, which is palpable in your physical examination and imaging. And this represents a very aggressive lesion. This will be all. I encourage you to do your further readings on your own, at your own pace and free time. Thank you.